Welcome back to part 9 of our Masterclass Explainer series on myocardial infarction coding. Today, we're bridging the critical gap between clinical pathophysiology and ICD-10-CM coding for type 2 MIs. If you've ever found yourself staring at a chart, wondering how to translate a complex ischemic event into a clean, perfectly compliant code, well, you're absolutely in the right place. Let's get right into it. We're going to kick things off with a scenario that honestly probably sounds incredibly familiar. You're reviewing a patient's chart, and the physician has documented a type 2 NSTEMI due to demand ischemia. Sounds straightforward, right? But here's the thing. This specific documentation string is a massive trap. It routinely leads to coding errors, denials, and serious compliance risks. So how exactly should this be coded? Here's our roadmap for this explainer. First, the type 2 MI mismatch. Next, assigning code I21.A1. Then, we'll hit the code first sequencing rules, and finally, wrap up with subsequent type 2 MIs. Section 1. The type 2 MI mismatch, understanding the pathophysiology. Okay, before we even open the rulebook, we've got to understand the clinical reality here. Think of a type 1 MI as a plumbing disaster. It's a spontaneous event caused by a primary coronary issue, almost always an acute atherosclerotic plaque rupture that just physically blocks the blood flow. A type 2 MI, on the other hand, has absolutely nothing to do with plaque rupture, literally nothing. It is entirely secondary to an ischemic imbalance. Picture a giant scale in your mind. On one side, you have myocardial oxygen supply, and on the other, oxygen demand. When that scale tips drastically, resulting in a severe mismatch, the heart muscle cells actually begin to die from the lack of oxygen. And that necrosis, that's your type 2 MI. So what exactly tips that scale? The most common clinical triggers include severe coronary vasospasms, profound anemia, where there simply aren't enough red blood cells to carry the oxygen, or dangerous drops in blood pressure, like you'd see in hypotension or shock. For the CDI specialist and coders out there, this means you need to put on your detective hats. When you see a type 2 MI documented, you should actively be looking through the physician's chart for these underlying etiologies. They're almost always hiding in there. Moving on to Section 2, assigning code I21.A1, the core tabular rule. Let's shift our focus straight to the ICD-10-CM rulebook. The official guidelines for coding and reporting are incredibly clear on this. It says, when a type 2 AMI is documented, even if the doctor specifically describes it as a STEMI or an NSTEMI, you are strictly instructed to only assign code I21.A1. That's it. The traditional MI codes you might be used to, everything from I21.01 through I21.4, are completely locked out. Those are exclusively reserved for type 1 AMIs, no exceptions. Now, we also need to do a little myth busting here because this is a really common error in the field. Coders often try to separately code the demand ischemia when a type 2 MI is already documented. Do not, and I repeat, do not, assign code I24.8, which stands for other forms of acute ischemic heart disease, to capture demand ischemia in this scenario. Code I21.A1 inherently encompasses that exact ischemic supply and demand mismatch. Double coding here is a definitive error, so just leave I24.8 out of it. Section 3. Code first sequencing rules. Let's build the hierarchy. Building the correct hierarchy is an absolutely crucial workflow step to ensure accurate DRG assignment. The tabular list actually gives us a mandatory code first dynamic. So, step 1, you must sequence the underlying clinical trigger, the etiology, in the primary diagnostic spot. If the mismatch was caused by anemia, the anemia code comes first. If it was hypotension or maybe paroxysmal tachycardia, that condition takes the lead. Then step 2, you assign code I21A1 for the type 2 myocardial infarction as the secondary diagnosis. Basically, the cause leads and the heart damage follows. Make sense? All right, Section 4. Subsequent type 2 MIs, navigating the 4-week curveball. Let's imagine this scenario. A patient has an MI, is discharged, but then they're readmitted to your hospital 3 weeks later with a brand new, clinically distinct type 2 acute myocardial infarction. It falls right within that critical 4-week window. So, what code do you assign for this new event? We actually have a major exception to the standard rules here, a real curveball. Normally, if a patient has a subsequent type 1 MI or an unspecified MI within 4 weeks, we'd utilize category I22. But if you look closely at the excludes 1 note under category I22, it explicitly locks out type 2 MIs.
Therefore, for a subsequent type 2 MI, you bypass category I22 entirely. You just assign code I21.A1 again. It really is that simple, but it trips up so many people.
So let's wrap this up. Master the physiological mismatch. Remember, it's all about supply and demand, not plaque. Always sequence the underlying etiology first, and firmly lock out category I22 for subsequent type 2 MIs. I21A1 is your single source of truth. But what happens if the underlying cause of the mismatch isn't documented at all? Are we just out of luck? We'll tackle those query opportunities in our next session. Keep these rules front of mind, and you're going to navigate these complex charts with total confidence. Decode Healthcare with Herschel.